Hi, everyone, and thank you for coming. We're going to start in a couple of minutes. We'll start at 8:35 p.m. IST sharp. While you're all waiting, a couple of quick announcements. If you're interested in today's paper, chances are you'll be interested in next week's paper as well. Exactly 1 week from today, next Thursday at the same time as today, 8:30 p.m. IST, Arvind Subramanian, Justin Sandifer, and Abhishek Anand will present their paper entitled Survey-Based Estimates of Excess Mortality in the COVID Pandemic. The discussant for that paper is going to be Murad Banerjee. So please join us next week as well. If this is a topic that interests you, you should consider joining us for the third event in a row this month, which will be on the 22nd of July, 2 Thursdays from today. I, Kaushik Krishnan, and Mahesh Vyas. Mahesh is the MD and CEO of CMI. He's also the principal architect of the Consumer Pyramids Household Survey. The two of us will be talking about the member roster in CPHS. The member roster is what makes it possible for both of these papers to be written. It tracks information on the members within the households that constitute the panel. The member roster is very useful in identifying deaths, as well as in identifying migration. We'll be talking about that in great length on the 22nd of July. So we hope that you'll join us for all of these events. Finally, if you are in the audience and you're a young or maybe not so young economics graduate and are looking for a job, we are hiring. So please see our LinkedIn pages and our Twitter page as well for details. If you're interested in working at CMI, please send me an email. My email address is kkrishnan@cmi.com. A couple of quick ground rules before we begin. Audience, all of you can type in questions in the Q&A box. While the presentation is going on, the authors will try to respond. If there are questions that can't be responded to in real time, the authors will try and pick that up after the discussion. So now I'm going to introduce everybody today. My name is Kaushik Krishnan. I work at CMI. I work on the Consumer Pyramids Household Survey. In particular, my job is to make the data from CPHS available to researchers. Along with me from CMI, I have Mahesh Vyas. Mahesh is the MD and CEO of CMI. Hi, Mahesh. Thanks for coming. As I said, Mahesh is also the chief architect of CPHS and is the best person to answer questions about CPHS when they come up. Discussing today's paper is Chinmay Tumbe. Chinmay is an assistant professor at IIM Ahmedabad. Chinmay, many of you will know Chinmay from his extensive work on migration. More recently, Chinmay has been working on pandemics and put out a book late last year, The Age of Pandemics. All of you are encouraged to go and check that out. The paper today is all-cause mortality during SARS-CoV-2 pandemic in India. This paper has been written by Anup Malani at the University of Chicago and Sabareesh Ramanchandran at UC San Diego. Anup and Sabareesh, you have until 9:30 p.m., that's 55 minutes to complete your presentation, after which it's over to Chinmay for a discussion, and then finally to audience questions if time permits. Anup, over to you. Thank you for coming to the CPHS Research Seminar again.
And thank you, Mahesh and Kaushik, for having Sabareesh and I present. I'm going to go ahead and share screen. Is everybody able to see the screen?
Yes.
Yep. Okay, great. All right. So we're going to talk about what we can learn today about all-cause mortality from COVID in India using Consumer Pyramids Household Survey data. This is joint work with Sabareesh from UCSD. Okay, quick overview of what we're going to do. Let me begin with the introduction. So as everybody knows, COVID hit India pretty hard. Arguably 45% of the population were infected, at least in some areas, even before the second wave. And the second wave peak in graphs that almost everyone has seen is much higher than the first wave peak. We know for sure that cases, the official confirmed case reports, are undercount the total number of cases. This is probably due to low testing rates. To some extent, serological studies can help us address this issue. They can allow us to figure out the number of people with antibodies and therefore the people that must have been infected. That allows us to scale up the denominator in a calculation of death rates. And when we do that, the IFR is going to appear much lower. And I'm maybe fortunately or unfortunately on record saying the IFRs are low as 1/10 of that you see in developed countries. But the problem with those estimates is that deaths are also undercounted. So it could be that IFRs that we've estimated using serological data is incorrect. Many news reports, including by folks like Rukmini, suggest there's massive undercounting looking at the official death count data, and then many others just pointing out that there are a lot of deaths that are not recorded. Of course, some people, including some that I've written in the past, express some doubt that there could be enough underreporting to overcome such a big deficit in IFR estimates. Today, we're going to try to answer whether or not that's possible. Okay, to address the undercounting, we need estimates of deaths. And ideally, we'd want estimates of deaths that are independent of not only official COVID counts, but maybe of all official counts. Independent of official COVID counts allows us to address the problem that the government might not code COVID deaths correctly. Looking at something independent of the official overall deaths might account for the fact that the official registration system undercounts all deaths. We're going to use the Center for Monitoring Indian Economy's Consumer Pyramids Household Survey, which has seen about 41,000 deaths since 2015, about 14,000 just since 2020. The data nicely extend till June 30th, 2021, so it's nearly the end of wave 2, although as I will talk about, we need to figure out what date to attribute those latest deaths to. We're going to offer different measures of death from COVID, raw data, some monthly rates, and then we're going to talk about heterogeneity across age, wave, and location. We'll also try to provide some baseline estimates for comparison. An important caveat to keep through all of this is that we're looking at all-cause mortality, not COVID mortality. And so we're going to capture not only deaths that might be due to other things like, say, lockdown, as some people assert, unrelated to COVID, but we're also going to capture increase in deaths due to other causes that we don't know about. So that's an important caveat to remember in this analysis. Let me give you a little bit of background on deaths in India. These are figures that come from the global burden of disease. Annually, before COVID, India experienced about 7 deaths per 1,000, so 0.7%. Death rate, there's about 9.5 million deaths a year. Again, GBD based on official numbers. Now, one thing I'm going to highlight here, because it can come up, notice that you see a slight dip in death rates even before 2019 and then jump up slightly in 2019. We're going to revisit that in a bit. Just keep that in mind, okay? You're going to see that in CMIE's data as well, but a little bit more exacerbated. Here's a quick look of the leading cause of death before COVID. It's what you'd expect. Heart disease, chronic respiratory illnesses, communicable diseases have been declining over time. Just kind of context. Now let's talk about the background of COVID in India. Here's a figure that everybody, the one that I mentioned that everybody's familiar with. If I had given this talk in November, December, January, February, we would have thought that this first wave was massive. And then we experienced the second wave. And here we're showing both cases and deaths. You see that the height of the second wave is much bigger than the height of the first wave, suggests that it could be a real problem. We've talked about separately, Sabareesh and I, in a Substack post with Satej Saran on what likely caused the second wave, some combination of a lot of susceptibles surviving the first wave, and also the Delta variant emerging, being much more transmissible, 40 to 60% transmissible. But the thing that's not obvious from this, and that hopefully our data will help clarify to some extent, is was the second wave actually more deadly, or did just more people get infected and you have the same death rate? In addition, something that we can't answer, but that is relevant is, did more people get infected in the second wave than the first wave? Okay, yes, the Delta variant was more transmissible, but also a larger percentage of the people had some immunity going into the second wave relative to the first wave. Another way to put this is the base of the first wave is much wider than the base of the second wave, to the extent that we can think that it's about to resolve. We're not going to answer the infection issue, but we're going to look at the death issue. Death rate issue. Okay, what do we know about what happened in the first wave? Why do I say that about 45% of the population might have been infected in that first wave? Well, it's because we've done seroprevalence studies in the last year. There are many of them, 16 plus sero studies, I think, done in India. I think we've done about 4 ourselves. Our initial one looked at Mumbai and found that in July, about more than 50% of slum residents were had previously had antibodies and therefore probably were previously infected, whereas the rates were much lower in non-slums. Then we did a statewide survey in Karnataka, including also Manoj Mohan and Anu Acharya, and we found 46% seroprevalence in Karnataka statewide. We did it again in Tamil Nadu with the help of Sabareesh and a team of government officers there, and the rate was 32%. Now, these are higher numbers than we typically find in government studies. But again, we want to be a little bit careful about how those studies are conducted, not to cast shade at the government studies, but they seem to systematically show less than a lot of the private surveys or purely academic surveys that were done. And we need to think about why that's the case. I'm inclined to believe the slightly higher numbers. And also remember that rates, when we're measuring 46% in August 2020, that's even before the second wave actually occurs. So I don't think that 50% is a terrible number or 45% is a terrible number. But this importantly suggests that we're massively undercounting cases, undercounting infections with confirmed case data by 20 to 100x. Now, as for the second wave, we're still waiting to see what happens with serology. We will very shortly hopefully announce the results of a sero survey that was done at the same time as the second wave occurred in Tamil Nadu, but again, it might not capture all the infections that occurred through the second wave. So we'll have to wait and see. We're seeing some hints of very high numbers coming out of places like Delhi. And so you might imagine the fraction of the population that's infected is quite high. However, we might not ever really discover the answer because one of the things that we're learning from serological surveys, when you do it repeatedly, even though cases are rising, the fraction of the population with antibodies don't always rise in these surveys. And the reason is because people infected long ago, their antibodies decline, so they might not be measured most recently. So antibody decline is a big confound for serology. So this is a tough question. So now let's talk a little bit about the mortality rates that we've seen. Let's start out with a CFR estimate, very crude. You could just get this off of numbers at covid19india.org or Johns Hopkins, right? Our CFR estimate is probably 1.3%. That's that you get that from a ratio of official COVID cases to official COVID deaths, to official COVID cases. There are about 400,000 deaths, 30 million cases roughly. I'm not going to try to get it to the very latest number, but that's roughly the number you're looking at. It's 1.3. But the problem is that the numerator and the denominator are undercounted. Now, those serology studies that I was looking at help you address the denominator, let you modify the official COVID cases to be actually infections. So you're moving from a CFR, case fatality rate, to an infection fatality rate, which you see in this fraction here. And that, if you keep the numerator the same, you're going to estimate that the IFR is, much lower, maybe 30, maybe 10 times lower than the case fatality rate, maybe lower still. In fact, the estimates that we find in India of IFR calculated the same way, so calculated in this way, are 10 times lower in India than they are perhaps in developed countries. Okay, but we want to revisit that. Okay, and these are just some of the figures that came. This shows that if we do it by age, it's going to be log linear in age, the IFR. This is coming from Anup et al. And this is a effort to compare the different serological studies and their implied IFRs by age to the developed country estimates, both O'Driscoll and the paper here. And you see that, in fact, we're finding that for a lot of the surveys, the death rates for all ages are much lower in India than elsewhere. Again, we want to try to inform that in this presentation. Now, our attempt is a little bit different than what happened in those prior studies that just replaced the denominator. We want to replace both the denominator and the numerator in our IFR calculations. So we want to replace official COVID deaths with, ideally true COVID deaths, but we don't have that. So instead, we're going to look at all-cause COVID deaths. That is to say, all-cause deaths during the COVID period. I'll be very careful about that, okay? Now, on the one hand, you like this move because official case counts are really low, so you might be underestimating death rate. But it's important to remember that all-cause death rates may be high or low, depending on what happened during the pandemic to deaths unrelated to COVID. So for example, maybe what happened was COVID triggered a lockdown, and lockdown is what decreased deaths or increased deaths because you didn't get access to hospitals for non-COVID ailments. That's kind of noise in that numerator. And so you will expect a lot of noise in this numerator, and you want to do what you can to try to figure out Is it more likely to be COVID that's driving this or something else? So we'll spend some time thinking about that. And we'll try to do this in multiple ways by looking at the age pattern in all-cause deaths. And we'll also try to say, how is it related to infections once you net out, for example, the effect of lockdown as measured by mobility. Okay. Now, we're not the first to look at all-cause deaths during COVID. There's been a heroic effort to try to get this data from different states, often in the news. For, I say, about 10 states we have this. It's now compiled at the Data Development Lab or Development Data Lab website. A lot of it's by folks like Rukmini. You have data from Madhya Pradesh, Andhra Pradesh, Tamil Nadu, and Kerala, and you've got the official death count, the official COVID death counts here, but then the actual mortality from the SRS and other official sources here. You see it's much larger. Now, this is a great effort. I particularly like it because these data that you're seeing on the screen try to capture deaths from all across the state. The universe is everybody in the state. The problem is it's not available for all states, and the methodology and the SRS might vary in terms of their performance across states. The merit to using our estimates is, while it's not the universe, it is a representative sample, and you get more states, nearly all 30 states in India, a few Northeast states notwithstanding, and you get a consistent survey methodology across the states. So there are pros to each. Let's talk about our methods. We're going to talk about the data very quickly, which many of you are going to be familiar with. We're going to look at case and mobility data and then death data. The daily case data is going to come from COVID19india.org. They have a very nice API that makes research easy. We're going to get serology data from multiple sources, but primarily going to focus on our Tamil Nadu survey from October, November. And we're going to scale that across India by comparing rural versus urban serology levels, and then scale it over time by looking at how cases have grown in different places over time. I can talk a little bit more later on about how we actually do this scaling. We use this in a number of studies, but it's an attempt to use a combination of confirmed cases scaled up by serology at specific points in time to figure out what serology is likely to be in different parts of the country today. You can do it with different serology data points that might not all agree. We do it with Tamil Nadu, but you can also do it, for example, with ICMR round 2, which is what we've also done. We get our mobility data from Google, as many people do. That's daily district level average mobility measures. Our death data are obviously going to come from CPHS. That's the heart of this presentation. Let's talk a little bit about that. CPHS is 174,000, is a panel data set covering roughly 174,000 households that have grown from, I think, around 165,000 households to over 174,000 households now. Covers about 1.2 million people, members of those households. The range is from January 2014 to end of June 2021. That's the latest data that have come out. Their sampling for this is based on the 2011 census. They generate 99 geographic district clusters around the country in urban settings and rural settings separately. Within rural settings, they're randomizing villages to sample in each of those district clusters. By the way, the district clusters are selected to be homogeneous to each other, but representative nationwide. But when they go and sample within rural areas in this, they randomly select villages. When they go to urban areas, they stratify by size of urban area and then pick cities. Within each location, they're selecting about 16 households to sample. In villages, it's a cluster of households. In towns, it's 16 households in a census enumeration block. Okay. Each household, importantly, you visit the same households, and each household is visited 3 times annually, every 4 months. And each month's survey is nationally represented. We're going to rely on that as we go forward. Now, CPHS wasn't designed to be a mortality survey. It was designed to measure income and consumption, among other things, and be nationally representative about that. If we're going to use the household roster in CPHS to measure mortality, there may be some issues. We can think of at least 4 issues that come up, some of them specific to COVID, and that we want to address. And then I'll spend a few minutes talking about now. The first is that there was a low response rate to the CPHS during COVID, in part because during lockdown, round 2 in 2020, they switched from in-person surveys to phone surveys. Second issue is you might imagine that households that respond are not random. that there may be non-random response to CPHS, and especially during COVID. We're going to show you that, in fact, households might have been more responsive to a COVID survey if they did suffer a death during the last 4 months. We have to address that. The third thing is what I mentioned before. There's a jump in deaths in 2019 before 2020. Is that a pre-trend? Did COVID start early, or was there something else going on and we're misattributing these deaths to COVID? Or is there something else? I'm going to talk a little bit about that. Last thing is I want to talk about the big problem, which is CPHS goes to each household once every 4 months. The households tell them if somebody died sometime during the last 4 months. The question is, which month do you attribute that death to? Okay, let's talk about low response rates during COVID. As I mentioned, CMI switched to phone interviews from March 20th to August 20th because of lockdown. The round-wise response rates fell. It was a laudatory or laudable 85% rate prior to COVID, but starting in round 1 in 2020, it fell to 65, mainly because of what happened in late March and April 2020, then fell to 45% in round 2, 72% in round 3 2020, and then 74% slight recovery in round 1 of 2021. Now, the main cause, I think, of the decline is because what CMIE did, is, from what we understand, is that they switched to phone surveys. When they did that, they wanted to have very competent phone surveys. So they had, instead of the regular surveyors, they had their managers actually doing the phone surveys. There are fewer managers of the survey team than the actual survey on the ground surveyors, and so they had to cut back the number of households they called. They randomly select, and they stratify first, and then they randomly select in each strata about half the households to sample, and then obviously not all of them might respond. And so the response rate was about 60% of the households that are called. Here is a table that shows this, shows the sample, the response rate given the sample by month in 2020 as the company switched to phone surveys. This is from a paper put out by Mahesh on the CMIE website. Now, it's important to remember that there's actually limited harm from the fact that some people didn't answer a survey during round 2, for example, in CMIE. And the reason is because they might have answered in round 3 and then told us, instead of what happened in the last 4 months, what happened in the last 8 months. Okay, so if response rates pick up, we can measure some of the old deaths. It only shows up as a problem in timing of deaths. When over the last, say, 8 months, rather than just 4 months, do I attribute these deaths? We are going to try to address this problem in 2 ways. The first is, without looking at that extra response rate, we're just going to say, of the people that respond in each round, can we use the non-response weights that CPS provides to scale up those numbers? And then to address the random and non-random response that occurs then, we're going to use a different method I'll talk about in a second. So let's talk about non-random response in COVID, during COVID. Remember, when they switched to phone surveys, we don't think that the selection of households by CMIE was a problem. Now, you may think that maybe it wasn't random, but we actually took a look at the data, and we tried to use all of CPHS's variables to try to predict which household CPHS actually decides to go visit each month. And we found that all the observables, and there's a vast quantity of them, can explain only about 4% of the variance in which households were selected for visit or phone call. Well, that's pretty good. That's about as close to random as you can actually see in real world panel data sets. So I find that quite reassuring. You might be worried about unobservables driving things, but I'm kind of inclined to believe that unobservables probably have as big an effect as observables roughly. And if observables have, especially this vast quantity, have such a small effect or explain so little of variance, unobservables probably do too. So I'm not worried so much about household selection by CPHS. What you might be worried about is, what about the response rate conditional on being sampled during COVID? Now, one way to test this is the following. Take a look at all households that, and let's use the letter T to signify rounds. So T is, say month 0, T plus 1 would be month 4 months later, and month T plus 2 or round T plus 2 would be 8 months later. Let's suppose that you have a set of households, some of which that responded in each of those 3 consecutive rounds, T plus 1 and T plus 2. And then you want to compare that to households that might have just responded in the first round and the third round. Okay. Now, because all these households responded in the third round, you have measures of all the deaths that occurred during this period. So you can kind of see during this period where there are more deaths in the people that responded in all three rounds or just the first and third round. Okay. And what you find in the figure to the right is that the respondents actually have higher death rates. So in English, if you are responding every round, odds are you have higher death rates. Or conversely, if you experience a death, you are more likely to respond in a round. Okay. So if you only use consecutive respondents in your analysis, you're going to get a higher estimate than if you use both consecutive and non-consecutive respondents. All right. The problem is we like to use consecutive respondents because it's going to make attributing the timing of deaths easier, because you only have to allocate over 4 months if everybody's responding in each consecutive round. If you go to non-consecutive rounds, you might have to allocate over 8 months or longer if they skip multiple rounds. Okay, so we'll want to use the consecutive ones. But as a check to see if that's a problem, we're going to use a weighted average of the estimates of deaths, looking just at consecutive folks and looking at non-consecutive responders. Talk a little bit more about that later. That is to say, we'll give our estimates later. Okay, third problem, drop in deaths in 2017 and 2019, or conversely, a jump in deaths in 2019. Okay, you can see that here, that there's this is all the deaths by month in CPHS over time. We're going to attribute them to the proper months in a way that I'm going to describe later. But what you can kind of see is that if you go after 2015, there seems to be a decline in deaths during 2016, 17, and 18 in CPHS. Okay, and then an increase in 2019. The red line indicates when COVID starts, and then increases further in COVID. On the one hand, you might ask, is this a pretend? On the other hand, you might ask, well, what's the right baseline? This period here relative to what was happening during COVID, or should we focus on 2019? All right. Now, before I begin, I want to point out CPHS is not alone in this. Even the official statistics, as reflected in the global burden of disease numbers, suggest that there's a jump up. You remember this figure here. It's just that CPHS has a slightly bigger jump up, which is right. I don't know. And the reason I don't know is because I have reasons to think that the official statistics might undercount deaths as well, and they might undercount the increase in deaths that you see in 2019 as well. So I don't know which of these figures is more correct. But if we assume that there is some sort of activity in 2019, you have to ask yourself, is it a pre-trend? And we don't think it's a pre-trend. And the reason why we don't think it's a pre-trend is because of the age profile of the jump in deaths you see from, say, 2018 to 2019 versus from 2019 to 2020. The jump in deaths you see from 2018 to 2019 has an age profile that's similar. That is to say, the age profile of deaths in 2019 looks like the age profile in 2018. However, if you compare the age profile of deaths in 2020 versus 2019, you see that the age profile here is more heavily skewed towards older ages. It looks more COVID-like in being, kind of log linear in age, or more log linear in age. Given that, we think that in fact what's going on in 2019 wasn't another thing. It wasn't just COVID starting earlier, and we don't think what happens afterwards is just some other non-COVID issue continuing through 2020. We actually do think that there's signal here and not just noise in the increase. Now, to be safe, when we think about the level effect, we'll want to use 2019 as our baseline for 2020, rather than using this earlier period. However, as a kind of robustness check, we'll show you both. All right, now the hard problem, timing of deaths. Look, our fundamental problem is that CPHS goes to each household every 4 months. It doesn't tell you which month the death occurred. Now, when CPS visits a household, the household may report a death that may have occurred that month, the previous month, or all the way up until 4 months earlier, the last time you came around and you asked them the question and they responded. Another way to put this is this table. Imagine a hypothetical world where the annualized death rate per 1,000 in months 1 through 10 is 7 in the first 4 months and then 9 in the 5th month, but then it goes back to 7. Suppose that's the truth. Now, we don't observe the truth. Instead, we get an observation from CPHS. And CPHS is going to take that jump up in 9, which is an increase in death rate by 2 per 1,000, and it's going to allocate it over 4 months. And the reason is because it's not going to go to all the households in month 5. It's going to go to a quarter here, a quarter here, a quarter here, a quarter here. And then they're going to report what happened some time ago. And our problem is, how do we back out the truth from CPHS? we're going to give you a simple solution and a more complicated solution, but focus on the simpler solution. The simpler solution is kind of just a moving average over 4 months. What we do is we only use individuals that are sampled in consecutive rounds. So we only have to allocate over 4 months, the last time they were surveyed, rather than longer periods. And then what we do is we attribute a death that is reported in month T, not round T, month T to month T minus 2, halfway between the now and the last time the household was surveyed, okay? And the way to think about this is it's kind of a moving average plus or minus 2 periods, 2 months in the back, 2 months in the future, all right? And this can be estimated with a regression of this format. I don't need to walk through it, but it's a format that says basically I'm going to take an indicator for whether or not you report the death 2 months later. If it's post March 2020 or say February 2020, depending on when you start the timing of the pandemic, that's the pandemic. If you want to separate out the waves, this is one wave, the first one, and this would be the indicator for the second wave, okay? Now, as I mentioned, this solution raises a non-response issue. Only about 82.5% of individual responders in a round also respond in the next round. So what do we do about the people that don't, especially if you think the 82.5% are different than the rest? That's where we're, again, to remind you, we're going to look at a weighted average of consecutive responders and non-consecutive responders to modify our estimate later on. So you'll see both what's your estimate if you look at both together, and how much does it change, maybe go down, if you look at both consecutive responders and non-consecutive responders. Here's a more complicated solution, and we'll explain why in some ways it's good, in some ways it's bad, but we won't be focusing on this in this study. What we're going to do is estimate the true death rate by asking the following question. What would the actual death rate have to be to explain the change in the observed death rate via CPHS? So if I observe that that the death rate rose from 7 to 7.5, what would I have to think the real death rate is in order to get that increase? Basically, we have to account for the fact that there's an increase and I'm only going to see a quarter of it in that month. And so I got to reallocate it to that month. This is the formula that we'll use in a very simplistic sense. There's a regression in the next slide that estimates it's slightly more complicated, but you can do this and then recover to some extent, subject to your starting point, the actual original death rate. Now, the advantage of this approach over what we did before is the approach before says, okay, if the death rate is constant over the course of a round across those households, then it's okay to reallocate by 2 months. It's not that big of a loss. But if the death rate is changing over a round, either increasing or decreasing, that moving average is not as good from a precise timing perspective. This approach is going to be better. The problem with this approach is that if there's a small difference in death rates, we magnify it. Remember, if you just go from 7 to 7.5, you need to assume that it's much bigger to account for the change. So if there's slight error in the observed, that error will get magnified as well. And so you're going to generate big variation through this kind of alternative method of attributing the timing. And so that's the downside. Now, we think that that generates some implausible variation. The averages look about right as you look over the entire pandemic, but within a round, we think some of the variation is slightly implausible. That's why we choose this as our robustness check rather than our primary method of allocating reported deaths to the appropriate month. Okay, let's jump to the results. A lot of methodology and background. I think this is what people want to see. Let's look at some of our primary results before we turn to heterogeneity. Time permitting, we'll look at what to do with immigrants, and then we'll look at IFR, and then talk about some of the policy implications or bottom line implications. Our general approach is going to be to give you raw data and then slowly add filters based upon our cleaning of the data so you can see exactly what each filter does and how we get at the final result. So you can judge for yourself whether or not our estimates are plausible, because they are going to be big changes, at least in the death rate, if not in IFR. Okay, so here you've got two figures. In your top, you've got your sample size in CPHS, and what you can see, and these are households that are actually responding, and you see the decline in the number of households that respond during the lockdown, and then the recovery once the second round ends. It's not a complete recovery, but that's an issue. You also see a decline in the response rate as we go into the second wave as well. Now, if we scale up to account for non-response, what is the death rate. Well, the death rate looks like COVID had a big impact, right? You see this big jump up, this big red bump here, and then some early evidence of what's going on in the second wave. But the problem is that there are other issues in the data we have to deal with before we conclude, oh my gosh, COVID really had a big effect. Also notice that this jump is massive. Even the raw data implies almost like 100% increase in the overall death rate in the country. That seems hard to believe. We need to tone that down using the appropriate, using data cleaning as required. Okay, so now we're going to show you efforts that first weight the data so that the raw data that you see in CPHS is actually nationally representative. We're now going to only use consecutive round observations. Okay, we're going to time shift the months T-2 as we explained, and then we're going to start the plot just in 2019 to deal with that baseline issue. And we're gonna do this through regression. So I'm going to be able to, what I'm showing you here is month by month, the coefficient on month indicators and their confidence intervals. That's the dot and whiskers. Okay, and what you see is this is 2019 in 2019 going through month 1, and then starting in February, March, you see there's a slight dip in the deaths, but then you see an increase in the death rate. And the interesting thing here is not only is these higher generally during the pandemic, but the peaks occur roughly around the time we see waves in the confirmed case data. So you're seeing something in September, October, and you're seeing something in March, April. Okay, that's starting to give you confidence that this is COVID and not something else. Now, I'm going to, instead of giving you month to month, I'm going to show you the regression results that will allow us to estimate with all our filters the baseline death rate and the death rate for the pandemic, and then maybe the pandemic broken down by wave 1 and wave 2. Now, the first thing we do is we use all the data to generate the baseline. So 2015 to 2019 as your baseline. And what you find is a baseline death rate that looks a lot like what you find in the official statistic. Not quite 7 per 1,000, but you're getting maybe 8 per 1,000, but within the ballpark. It's still higher. A topic that's worthy of exploration independently of COVID, by the way. But we find that the pandemic effect seems remarkably high. And again, the reason is because the death rate before 2019 was very low. Something that we need to try to understand. Now, if to be more conservative, we switch to 2019 as the baseline, so we're looking at data from 2019 onwards, the baseline death rate is higher, meaningfully higher than you find in CBD or the official statistics. It's 1 per 1,000, but the estimate of the effect of COVID seems a little bit more plausible, about 0.185%. Okay, and that's going to be our kind of frontline estimate. We'll modify that downwards in a second, but at least in our consecutive round data, that's what we're going to look at. Now, you can add fixed effects that allow for geographic heterogeneity, and you're going to get slightly smaller rates, but roughly consistent there. Don't worry about this baseline number because I'm not showing you all the fixed effects for each of the homogeneous regions or each of the districts. Instead, I want you to jump. The next result I want to point you to is this fifth column. Here, we're taking the 2019 to 21 data, just like in the second column, but we're splitting the pandemic indicator into wave 1 and wave 2. And when you do that, you see that the death rate in wave 1 is a little bit lower, 0.119, and then death in wave 2, it's higher. So overall, we're seeing COVID, we probably think, just looking at consecutive responders, COVID death rate is 0.185% in the annualized death rate. If we break it down by round, second round seems more severe than the first round. We might want to ask ourselves why that is. Maybe the Q&A is the appropriate time for that. Now, as I pointed out, we focused on responders. What if we look at non-responders? As I mentioned, the non-responders have higher death rates, and particularly so during COVID. And so you want to figure out what to do about this fact. You want to maybe take a weighted average of the two to account for them. And we'll try to do that. But first, to illustrate what the magnitude, or to show you what the magnitude difference is before we illustrate that or estimate that composite death rate, we're going to show you what the death rate is for people that are consecutive responders versus non-consecutive responders through this regression framework, where this term, it identifies people that are consecutive responders generically. And this is the interaction between, are you a consecutive responder, and are you during the pandemic? Are you responding during the pandemic? And what do we find? We find that respondents, people that are responding to consecutive rounds, tend to, even before the pandemic, have a higher response rate, more likely to respond if you've had a death. You want to express that. But in the pandemic, that effect increases such that it's 0.17 higher. Now, if we take the implied by this, we take, what is the implied death rate for non-responders? What is the implied death rate for responders? Weight the two based upon the fraction of the sample that are responders. There's far more of those than there are non-responders. What number do we get with? Our composite death rate, and again, we in a regression framework, is 0.153%. So a little bit lower. Again, it's skewed towards the responders, consecutive responders, because there are more of them in the sample. Okay. Now you've got that number in your head. You can either choose that 0.185 or 0.153%. That's your overall death rate. That's all-cause deaths divided by the population. Okay. Now, and that's over the course of the entire pandemic, by the way. Now let's look at how this varies by things like age, gender, location, etc. We already talked about timing, so that heterogeneity is already discussed. What's very interesting about this is that the age pattern of excess deaths during COVID is closer to log linear. Now, as it is, the age pattern of deaths even before COVID, the death rate was higher among older populations. That's the black dot and whiskers that you see here. But if you look at the red, you see that the red figures actually exacerbate that. In fact, interestingly, although it's not significant, the younger folks actually have a slightly lower death and the older folks have higher death. It's kind of a tilt towards the older folks, a little bit more like what you're seeing in COVID. We're going to show this in regression analysis shortly too. Now you can try to break that apart by wave. So here now I've taken that red dot, I've got a gold dot and a red dot. The gold dot is wave 1 and the red dot is wave 2. And both of them are skewed in terms of their increase, their excess deaths towards wave 2. Okay. So that's interesting. So that 0.185% excess increase in death rate, that's excess deaths, looks a lot different for older people than younger people. It fits that COVID age profile that people talk about, the log linearity in age. Okay. Now, I also want to talk a little bit about what happens with males and females. And by the way, I just want to illustrate, these are regression coefficients. So I'm not showing you a different regression result. These are regression coefficients. So when the confidence interval lies above the confidence interval, lies above the black confidence interval, you know it's a statistically significant increase. The statistically significant increases occur at the higher ages, not at the lower ages. Sorry. Now back to gender. What's interesting here is we don't really see a difference in death rates, at least in the all-cause numbers in CPHS, either before or during the pandemic. They're very small differences, not statistically significant, maybe slightly more like a small adjustment towards females during the pandemic, but again, very much not significant. So I wouldn't make much out of this. This is very close to zero. Now, that might lead you to think, well, based upon the official data, it seems like males should be dying at a higher rate than females conditional on infection. Yes, CPHS data is not showing that. That could be because CPHS is not reliable. I don't think that's the issue, but it could also be because the non-COVID or indirect COVID related effects are affecting females a little bit more. Both are plausible explanations. I don't know which one is right. The age pattern is consistent. I'll say gender isn't. And I'll also say the location one isn't entirely either. So it is true that urban areas in CPHS have a higher death rate. You can see, and especially during the pandemic, and you can see that right here, pandemic times urban, the interaction, but it is not statistically significant. If you try to break it down by wave, you find that there's actually not much of a difference between urban and rural in wave 1, but in wave 2, the urban have a much higher ratio. That's what the statistics tell you. I don't have a great story for this, and I don't want to give you some post hoc stories about why that might be the case. My big takeaway is we don't see a big urban-rural pattern in the death rates. Now, remember, it is possible that the infection rate is in urban, but the death rate is lower in urban. For example, if there is better healthcare, for example, or those are healthier individuals. So it could be that the differential pattern in serology wouldn't necessarily show up in the death rate. So this I find a little bit less telling than the gender differences in terms of issues to make you wonder whether or not we're getting the right answer in CPHS. I still think we are, but I think that it's important for you to note that. Now, I'm going to look at time here. let me do this. Let me try to tell you a little bit about immigrants, but I'm going to try to do this quickly because it's not central to what we're doing, but it's an important issue that you ought to know about before we jump to IFR. Okay. The sample in CPHS goes to, or the surveyors in CPHS go to each household. In each household, they compute a roster and they ask about people in that roster. Now, they also have the roster that was collected the last time they were there. So if somebody was there and then left the house, they emigrated away from the house, they would know that and they can ask about it, okay? Now, if those people return, they become part of the household. CPHS only counts, for the purposes of their analysis, the people that are currently residing in the house. So they track the immigrants and the number, but they don't actually count them and they don't include them in their weights, all right? Now, what is it that we observe about immigrants in the data during this time period? So going from, say, 2019 to the present. Well, in general, there's a net outflow of individuals from the households, and it accumulates over time. Maybe your daughter leaves and gets married. Maybe your brother leaves and decides to form his own household in the city, things like that, and they don't come back. There's a net outflow, and if we look at the cumulative number of immigrants over the course of the entire survey, you see that it's increasing to the point where about 22% of all the people ever rostered over these 5 years in CPHS, about 22% of them are now in the category of non-household members. They're immigrants associated with that household, okay? Another thing that's interesting to note about this piece of data is that there's a big jump in the number of immigrants that returned home during the first wave, okay? And then you can see that here. So keep that in mind as context. These are not officially included in the numbers, but CPHS makes track of them. And in fact, you'll find out if they died, because CPHS asks, hey, first let's run through the people that are in your household that are here now, but now let's look at the people that emigrated away. Do you want to tell us that those guys are still alive? They obviously ask it in a more formal way than I'm telling you, but they are able to pick up deaths of immigrants, even though we're not including that in our analysis. The question is, can we and should we make hay of this fact? So I want to talk a little bit about that. Now, in general, we're going to assume that the time allocation, that we're going to assign the death of an immigrant in kind of in the same way that we assign the death of a non-immigrant. That is to say, we'll assign it to the period sometime between now and the last time we asked this household to tell us about their immigrants, even though the immigrant wasn't there. So it's sometime between this and the last survey if they're consecutive, 4 months ago, if they're consecutive responders, okay? Now, if we do that, what we see is a sharp increase in the death rate among the set of people that are immigrants in the CPHS. Again, it's not in our analysis so far, but it's important to note that it's an increase, and then we see a decline, all right? And that's pretty big. And in fact, if we look at all the deaths that show up in CPHS, including immigrants and non-immigrants, about half the deaths are from immigrants, okay? And so that's kind of an issue. It suggests to look, is there some signal there that we can use? Now, the problem is CMIE's sample is not designed to be representative, including the immigrants. It's designed to be representative, including the people that are just residing in that household at that time. So it doesn't include, including immigrants doesn't make it representative, it's representative without it. And also CMIE, therefore, does not provide weights to account for the immigrants, even though there are a lot of deaths that might occur from there. Our solution is we listen to CMIE. CMIE has calculated its weights to be representative. So we're going to give primary estimates excluding the immigrants. We will do robustness checks that include the immigrants. And then in order to conjure up weights for them, we use the household weights. But that's not going to be perfect. And the reason is because those household weights are designed to be representative given all the households in India. If some of those immigrants went away and started their own households, then we're kind of double counting them. And so that would be incorrect. You need to know the fraction of immigrants that go away and start their own households in order to figure out the appropriate weight. So we don't have a very good weight to use for this. Now, the other thing that's really concerning about this, the using the immigrant data, is that the increase in deaths we see in immigrants, so remember it's this bump up right here, is perfectly coterminous with the time that CPHS switched to phone surveys. And then when they switch back from phone surveys, the numbers decline. Now, importantly, remember, that the people that did the phone surveys were the managers, not Mahesh and Kaushik, but the managers of the surveyors rather than the surveyors. And maybe they were more rigorous in their asking, or they asked in a different way. And maybe what happened was they just picked up more of these deaths or picked up backlogs of deaths more correctly. And so if that's the case, and if it's a surveying method problem, we want to be a little bit careful about using those data. We don't see similar sorts of jumps up during wave 2 when they didn't switch to phone surveys, but there was an increase in actual cases and likely deaths. So we're inclined to think that it's probably not good to use, at least among immigrants, those 4 months. We don't see the same pattern in the non-immigrant death data, so we're comfortable using those even during the first wave. So again, our primary estimates are not going to use immigrants. If we do, however, just want to show you what goes on, the main thing to take away is including immigrants will increase your death rate. And that's not surprising. A lot of those immigrants died, and they all seem to have died during the second wave because that jump up during that telephonic survey that was done during round 2 of 2020. But again, we wouldn't want to use this immigrants. The weights are not right. There are issues with the way the survey was done that make you think that it could be a survey style issue rather than the actual true signal. Now I want to give you all, I want to give you a kind of a variation of infection fatality rate. Okay, so remember the infection fatality rate is COVID deaths divided by all COVID infections. You get the denominator typically through something like serology. That's not perfect, but that's what you do. What do you do about the numerator? Well, the reality is we have no way to measure COVID deaths in the population overall. Okay, no, we can talk about it a little bit, but generally not one that's widely available. You can try to substitute all cause, but remember all cause is going to both pick up COVID caused deaths as well as indirect COVID caused deaths, meaning like COVID triggered a lockdown and lockdown caused people not to go to the hospital, or maybe decrease the death rate because it stopped traffic and traffic accidents. But it will also pick up any kind of non-COVID related things that are totally independent. Some other disease shows up or doesn't show up, like say seasonal flu. So that's going to be an issue. So when we say all cause infection fatality rate, just keep in mind that fraction. It's all cause death divided by infections. If you want to attribute all causes of deaths to those infections, that's what numbers, this is the rate that you're going to get. Okay, so that's a very important interpretation. The way that we're going to estimate this is the following. We're going to take the death rate per month and we're going to regression against the imputed infections from both confirmed cases and serology each month. And then we're going to also try to adjust try to get a little bit more COVID-like by getting rid of, filtering out the effects of mobility. So we want to get rid of some of the following effect. COVID causes people to socially distance voluntarily or cause the government to require social distancing, say lockdown. That reduces traffic deaths or changes your access to hospitals for non-COVID illnesses, whatever that is. We want to filter that out. To filter that out, we're going to include a measure of Google mobility. Okay, it's not going to make a big difference to our estimates, but we're going to include that. And we're going to show you these estimates in the next slide, in 2 slides. Again, as I said, we're going to get our infection data from the Tamil Nadu curve. So think about the way we do this. For each state, so let's start with Tamil Nadu. You draw out the confirmed case data over time. Then we know we did a serological study that says the fraction infected is much higher than the confirmed cases suggest. So we scale up the confirmed case vertically curve to make it so that what level would it have to be to have generated the serology that we saw on that date. So it's a vertical shift. Then when we do it in other states, we first take the confirmed cases, and then for the shift up, we say, if we assume that urban-rural serology is the same in Tamil Nadu as elsewhere, what would serology have been in this state at this particular time, and then scale up their curve. Now we can use that scaled up curve to figure out how many infections there were by each date. And then we can correspond that to the deaths we observe by each date. That's how we're doing this, okay? If you do this analysis, this is the regression result you get. You're going to find an overall, and again, I want to be careful, all cause IFR. This shouldn't say overall IFR, it should say overall all cause IFR of 0.03%. That is meaningfully lower, about maybe 10x difference that you see in developed countries numbers, okay? Now, the thing that's reassuring about this is that it is increasing in age, where the older ages are the ones where you're seeing the biggest increases in absolute value, and also statistical significance. These are the ones that are statistically significant. So it has that COVID-like age pattern to the change on infection. But again, you have to figure out what you're picking up. So I want to talk a little bit about interpretation here. Okay, why is this estimate here lower, 0.03? Why is it so much lower than the overall death rate estimates of, say, 0.185 or 0.15? You might think, oh, look, if you think even 50% of the population, maybe that's an underestimate now after the second wave, but if you think that 50% of the population was infected, the difference between the death rate before, it's deaths divided by population, whereas here you're taking deaths divided by infections. You might say, well, shouldn't I, if infections are only 50% of the population, should I just change the rate? Shouldn't this number here instead be something like 0.09, about half? And the answer to that is, or higher, actually double. The answer to that is no, for multiple reasons. One is that your denominator is measuring something different. In one, your denominator is measuring your overall population each month, which is constant, whereas with IFR, it's measuring the fraction of the population that's infected, which is a much smaller estimate. So it should be, if anything, higher, but it's a different measure. That's the first thing. The second thing that matters is how good your infection scaling is. So if you don't like our Tamil Nadu numbers, you think that they should be higher, then you'll get a lower estimate of IFR. If you think they should have been lower, like we're overestimating it, you'll actually get a higher number. It's also important to keep in mind causation in this context. When you're looking at overall death rates, you're not saying very much about COVID at all. But when you think about IFR, you need to ask, what question are you getting? Are you trying to get a but for causation? That is to say, how many people would have been infected but for COVID? That's what we're picking up. Or are you trying to get proximate cause? This person, this elderly gentleman might have died in 2019, but in 2019, he would have died of cancer, and now he's dying from COVID. So I'm going to look at it as a proximate cause either way. In general, when you look at folks like the existing studies of IFR, which have higher estimates, those are numbers that are doing proximate, whereas these regression results are looking at maybe something that looks a little bit more but for. Okay. I would want to focus on the death rate. So I'm going to focus on that a little bit in our discussion. So CMIE, a few takeaways. First, CMIE's data suggests there's a higher baseline death rate before COVID. Remember, GBD and the official statistics suggest a baseline rate of about 7 per 1,000. We find that the death rate before, during the period 2015 to 2019 is a little bit higher than that, 0.79%. So that's almost 8 per 1,000. And if you focus just on 2019, it's 10 per 1,000. So that, even if you weren't talking about COVID, that's worth investigating and keeping in mind. It is possible that we're overestimating the death rate underestimating the death rate with official statistics, even before COVID, or it's possible that that the death rate before COVID is even overestimated in CPHS, and that should be adjusted for. Now, focusing on COVID, our analysis implies that COVID increased the all-cause death rate conservatively from about 1 per 1,000 to about 1.25 per 1,000. That's about a 17% increase in death rate. You might want to compare that to, say, other countries, say the US. In the US, the recorded increase in the overall all-cause death rate is about 22.9%. So it's in the ballpark, although a little bit lower than the United States. This all implies about 3.35 million excess deaths from COVID. Okay, that's a very large number. That's much larger than the official number of COVID deaths. If you adjust for the non-response bias, that is to say the people that are not consecutive responders, the numbers go down to about 2.77 million, maybe a somewhat more reasonable number, but still much larger than the existing numbers. The existing numbers are 400,000. So if we think of this as a but-for cause associated with the COVID pandemic, including lockdown and everything like that, the official death count is underestimating the overall number of excess deaths by about 5 to 10x, depending on what part of the confidence interval you want to use. So a massive undercount. Again, consistent with what individual state level answers are giving you. Okay. Now you might ask yourself, should I believe these guys? Well, I'll give you a few reasons why I think you ought to, and then we'll talk about some of the limitations. So I think the best reason to believe these numbers is that the timing matches the 2 waves of the pandemic. It's also the case that the age profile, the incremental excess deaths during the pandemic fits the kind of COVID age profile you see in a lot of studies across the world. Non-response is an issue, but we're addressing a lot of non-response issues either by using reweighting or trying to see if they report later on and then reattributing. Okay. What's really interesting also is that this is fairly stable results. We can add controls and you get similar results. You can move the cutoff dates for various things, and you're going to get roughly the same numbers for, say, the pandemic. Now, what are the limitations? And there are many, and I'm hoping to learn some more from y'all and Chinmay. But here are four that we think are big. First is, again, we're going to repeat it a number of times, all-cause mortality, not COVID mortality. Second, the big jump in deaths in 2019, pre-trend or not, again, there are arguments in each direction. Third, the timing of deaths has to be imputed. That's an important thing to remember. This is a limitation of the CPHS data. Our answer to that is to look at it multiple ways. And aside from additional variance in the alternative approach, the levels look roughly similar, but timing of deaths remains an issue. And the last issue is you might think that there's still kind of non-response bias, especially later on where we can't say, you know, the people that reported in, that didn't report in April, we don't know what really happened to them. It might be that they'll tell us, but we haven't gotten those data yet. It'll take 4 more months after April to get those data. We're not there quite yet, not till August. Okay, with that, let me stop and turn it over to Chinmay. Thank you very much. I hope we didn't go over too much.
Thanks, Anup. This was really interesting, but before I step in, I'd like to bring in Chinmay. Chinmay, thank you so much again for agreeing to be a discussant on this paper. We know that you are also grappling with this problem. So we're all very interested to hear your thoughts. Chinmay, over to you.
Great. Can you hear me? Yeah.
Yes.
All right. So thanks a lot for that, Anup and Sabareesh. Very fascinating work, and I think this is probably the first time that a household survey has been used to estimate pandemic mortality in India. And the numbers, I mean, the first big takeaway is, of course, that the overall number that you give at the end is definitely on the higher range compared to what people working on, say, CRS statistics are. Though, of course, nobody really knows. I mean, later on, we might find out with more information, more data, that many of these ranges were on the lower side. It's completely. But my first kind of takeaway is, if you see the big picture that's emerging, from your work, is that it's substantial. However, whatever your lower range or higher range, you're talking about 2.5 to 4 million, excess deaths. So that's a lot of excess deaths, which I think is much more than what's coming out from the CRS estimate. I think there are a lot of strengths in this approach. What I'm going to do is I do have a few slides. I'll first start off with a small historical context, because I work on economic history, and I think it's useful to kind of know what how people estimate pandemic mortality in general, and then come to more specific comments. A lot of it, of course, you've already pointed out in your limitation section, and I think there are a lot of questions as well on the chat box, which I think we should give time for that as well. Right. So I'll start with the last time India had a pandemic generated a lot of studies. So what Anup has presented is in a long tradition of estimating pandemic mortality in India. But this is just a table summarizing all those studies. What's curious is, of course, this is about the 1918 influenza pandemic. The first estimates of deaths were 5 million. This is when the pandemic had just happened in 1918, and in 1919, Norman White said 5 million. I just want to kind of focus on a variety of methods, but broadly over time with more refined demographic estimates and so on. It's amazing that these numbers kept going up. So it's almost like a upward drift towards these estimates on how many people died in the influenza pandemic. Also note, of course, that time you didn't have the CMI CPH survey, so you could not do what Anup was doing for 1918. But typically, in terms of how people have used methods, is essentially based on two methods. One is intercensal growth. That's why the census of India is very important, and that is going to give us additional information. And the other is, of course, excess mortality based from CRS statistics. Right. So this is a kind of a backdrop of that, and also to put what Anup and Sabareesh are doing in a larger historical context of just how large are these numbers. These are now numbers, if we are to believe them, 2.4 to 4 million is right in the ballpark of. It enters this table of the worst demographic disasters ever to land on the Indian subcontinent, right? So if you see this table, 20 million is influenza, but if you go at the bottom of the table, for example, Bengal famine of 1943, by some estimates, 2 to 3 million people. We are looking at a pandemic, which, by the way, has been the shorter time period in the pandemic compared to many of these events mentioned here, and as many deaths. So this is, if these estimates make, of course, the pandemic one of the worst disasters to hit the Indian subcontinent since at least 60 or 70 years. Again, just this is work of Siddharth Chandra, but just to point out the extent of difference between the waves back then, and so coming more specifically to monthly variations, 1918, you kind of get these crazy spikes in data. And I'll come back to this, when looking at Anup's work, but you get, death rate spiking up by about 5 times, right? From the usual, this is again all-cause mortality data, but you're getting monthly death rates, jumping up from about 3 to 15 in November 1918. So that's the kind of laws. I mean, that's happened in the past during the influenza pandemic. Again, this is of course work of Rukmini from the recent pandemic, which kind of again shows you the devastating impact of May. But I'm just going to point out a little bit out here because it has relevance to what Anup and Sabareesh just pointed out. That is, if you look at Andhra Pradesh's chart, Andhra Pradesh is a state which has good death coverage and so on. You will see that you can clearly kind of pick out the excess mortality, not only for the second wave, which is May pretty much, but also August and September, right? And so you can actually see the first wave effect and second wave effect very close. And that's why the months really matter while doing any analysis of the first wave and second wave and so on. All right, so more specific kind of comments on this. One is, of course, all researchers grappling on this question, as Anup mentioned, what they're looking at is all-cause mortality. The thing is, of course, eventually, of course, one starts using words like, this is, for example, when you come to infection fatality rate, you are using all-cause mortality then in the numerator. And, so in that sense, all-cause is entering that equation, but you're still calling it infection fatality rate in the sense of being specific to COVID-19. I don't know how useful the CMI could be, the survey to kind of give us more light on the split, but precisely because I think the great value addition of this paper has been in, for example, estimating IFR and so on. I think some potential ways to think through what might be leading to these excess deaths apart from COVID-19 would be useful. And I think that there might be a way to do that by just mapping out, we didn't see, I think, enough charts on months. You showed us death rates, increasing over time and so on. But I think really mapping it out on the months, especially on the reported months, right? A nice chart on that would really tell us, when exactly are the death rates spiking, and is it really matching, after doing all the imputation work, is it really matching the waves that we are seeing in the reported thing? I think that would give you a kind of slightly better idea. The one thing which I did find puzzling, which I also find maybe hard to accept, is the regression result on wave 2 having significantly higher urban death rates. In the sense, and the puzzling part here is that you don't find that effect in wave 1, right? Which is probably counterintuitive in the sense that if we just observe based on partly reported numbers, partly ground level reports, you would think that wave 1 was almost entirely urban, and wave 2 actually it moved into rural areas. That's the narrative which I think people have. So this is very counterintuitive, and you mentioned that you don't really have a good story arc for what's happening there. But I do think it's a puzzle. If this is what the data is suggesting, were we then underestimating rural death rates so much in the first wave? The gut feeling says, no. It's quite likely that the first wave was much more urban. So this is definitely something which I'm finding it very hard to square with all the ground reporting. If you just see the comparison between wave 1 and wave 2, because I think a lot of us have got into this head that wave 1 was much more urban, had a much more higher death rate, because what you're pointing out is death rates. So death rates being higher, significantly higher in the second wave vis-a-vis rural areas is a bit hard to square with some of at least the anecdotal stuff coming from the ground and so on. Maybe this is the truth, right? In which case we'll have to revise how we look at wave 1 and wave 2. But I do think you probably need to spend more time in understanding what's happening there. You mentioned I think it's fairly plausible and convincing as to how you allocate the timing of deaths. It's a very tricky issue. I know from household surveys. But again, I think you should also maybe have some charts just showing the monthly kind of thing very closely, because we do know that up to August and September last year, and May of this year were just crazy. I mean, if you see that, the high excess mortality in wave 2, it's really a May effect, I would imagine. And so it might help to actually even break down wave 2, however crudely, maybe, not really possible, but you would assume, I think it would give you, much more confidence in these numbers if you actually see the May effect, if you can actually demonstrate the numbers going very high in May, which is what we're seeing in the CRS. The one consistent pattern in the CRS data is the signature spike of May. And note, it's not a lag because, in many of these states, the deaths are registered within, almost all deaths are registered within 21 days. So it's not that the April deaths are being registered in May, it's pretty much a May effect, which is huge. So I think that would be a good addition to the paper. I think you've talked a lot about 2019 baseline. For those who have not followed this discussion, it's just intriguing that 2019 sees a spike in not only CMI but also CRS statistics, that is the civil registration system, which is a kind of a puzzle. And I think, as Anup said, maybe demographers and various people have to also look at what was happening in 2019. Another point of concern was the extrapolation of Tamil Nadu. Now, this I know is a standard epidemiological way of going about things. I think Gautam Menon's paper also uses the seroprevalence of Karnataka, to extrapolate the overall model. But again, here, because the extrapolation is done for such large period of months, for all of the country, especially my sense is the impact, the regional variation of mortality impact, and also infection, getting infected, was much more common, in the sense much more of India got this COVID shock in 2021 than in 2020. Right? So to use the Tamil Nadu extrapolation in late 2020 across India, one would like to see a few more robustness checks there. That is different scenarios so use that urban share to project it, but maybe use some other metrics as well. One thing you can use is actually use the reported numbers. If you think that the reported numbers are doing a decent job in projecting the first wave, then using some of the reported numbers to extrapolate, or to use it just like you're using urban shares to extrapolate the seroprevalence numbers from Tamil Nadu to all India. Because I think this is something which I think a lot of questions will be raised. And finally, on location, I think the location you're looking at really right now is migration, emigrant, and source. But I think the huge value addition would be just to look at states and just see what's happening. I mean, you have the all India chart. Maybe this is low sample issue, I don't know. But I just think that there's huge value in showing, state level, the same death rates that you're showing across, do it for states or the district clusters which CMI is focused on. Because I think that's very useful, because if you compare that and to show a comparison of that with the reported numbers, right, reported deaths across states, because that has huge policy relevance as well, in the sense, if your trend line death rates using not trend line, but the series, the death rate series that you're computing using CMI across states is similar to the reported COVID deaths across states, one would still say there's some value in the reported COVID deaths in terms of at least seeing which states are being affected at what points of time. Right? And my null hypothesis would be that it's a completely different thing. So your state level time series would be very, very different from the reported numbers, because that's what we're getting from the CRS. Karnataka 4 times more unreported than Andhra Pradesh, and Andhra Pradesh much more than Karnataka, for example, on excess mortality. So in terms of kind of comparison states, and so how do they correspond with state level? Finally, on mobility, this is probably a scope of another paper. Do restrictions work? But I think now that you have the death rates, I think this is a fair question to ask. Because I think the second wave the first wave is all common across India, but in the second wave you have so much of regional variation in mobility reductions. Did districts or states with faster mobility reductions see lower death rates and so on? These obvious follow-on questions that would emerge. But it might be also interesting to look at the mobility data closer, just to get a sense of, because I think, of course, the states mandate the lockdowns and the mobility falls, but in a lot of places, the mobility started falling even beforehand, as people themselves realized that you have to take precautions and so on. And seeing if there's some relationship between death rates and mobility reductions would be an obvious follow-on steps. So the broad thoughts, really enjoyed the paper, and there's no doubt it's going to, a lot of this work on mortality is going to completely revamp our understanding of the pandemic. And this is a very, very important contribution towards doing that. So with that, I'll end, and yeah.
Chinmay, thank you so much. Anup, would you like to respond? You and Sabareesh, would you like to respond to some of the points that Chinmay raised?
Sure, and I'll try to do it as quickly as possible. So first of all, thank you, Chinmay. Those are all amazing comments. I also think it's very important to keep in mind what's going on now relative to what happened in prior pandemics. There's some commonality across them that can be informative, and we need to keep that in mind. You raised a number of great comments in your last slide, so I want to go through them linearly. The first one is looking at all cause versus COVID-specific deaths. I think that's exactly right. We need to break it down. We are working with CMIE to hopefully be able to do a project where we go back to individuals who died and then do a verbal autopsy to figure out what they might have died from, and if it's potentially be COVID. It's still a survey that's we're still planning, and we can't be 100% sure we'll be able to finish, but we're going to try to do that for the reasons you stated. On wave 2 deaths being more urban, we were slightly surprised too, but I want to be careful about a few things here. First, the number of cases and the number of deaths are a little bit different because it depends on whether or not, so if you just look at urban versus rural, it's not always the case that urban deaths will be higher. Now, the thing that's puzzling about ours is that urban deaths in wave 2 were higher, but urban deaths in wave 1 were not higher. How could that be? Now, I'm going to be careful here. As Sabareesh likes to warn me, post hoc explanations are very easy, but they're not necessarily correct. So here's my post hoc explanation with that caveat. What I suspect happened during wave 1 and wave 2, based upon an array of data, is that in wave 1, you hit urban areas more than rural areas, but you hit urban poor more than urban wealthy. The urban wealthy were more likely to be able to socially distance through the first wave. But what that meant is that coming out of the first wave, you had a bunch of high SES people who tend to be a little bit older too. That is to say, they're more likely to survive when they're older, and they're more likely to be able to live with comorbidities. And they're ripe for infection for wave 2. Wave 2 comes along, again, it's more urban, but this time the death rate is higher among them because you're tackling this population that has more comorbidities. And maybe that's the reason. Now, there's a few more things we could talk about there, but I think that there are plausible post hoc stories. Whether they're correct, I think requires more work. On timing, you are correct. We should do more on the monthly stuff. And in fact, I particularly love your suggestion of comparing the timing of the monthly excess death to our timing of deaths and comparing that to different methods of our timing. I think that's good. You can actually go a step further and recalibrate the reallocation to match the official numbers. And that might be an interesting third approach that we hadn't thought about, but that your comment brought up. Then you talked about Tamil Nadu extrapolation. You're exactly right. It's too much to do for one sero survey. Now, what we typically do, we only present at Tamil Nadu, but we typically do 2 or 3 different approaches, primary Tamil Nadu, then we do ICMR, but the overall levels in ICMR are lower. So there might be a con there if you think those are too low. But ultimately, we'll want to use the latest data that's available. Now, one issue with using multiple sero surveys is they're often inconsistent. And that's typically because of 2 reasons. One is because there's sampling differences across them, maybe methodological differences. And the second one is there's antibody decay. So when we went to Mumbai in July and then we went in August, basically we found, even though the cases were rising still fast at that time, seroprevalence was the same. And so if you're trying to rescale those confirmed cases by sero estimates, you're going to find inconsistency because of that decay. So that makes this problem problematic. But we will try a bunch of those scalings. Now, the key thing to do for this is to realize this is a limitation of all cause IFR estimates. However, the one thing that you might be able to take away from this is as long as your estimate of infections is monotonically related to actual infections, then you're at least figuring out if areas with more infections are more likely to have COVID. And if that's COVID deaths, or have deaths, I should say, that should then give you some more confidence that, in fact, when we look at excess deaths in 2020 and 2021, we're really picking up a COVID pandemic as opposed to something else. So it, along with the age profile and the timing, are things that make us a little bit more confident that this is a COVID effect rather than, say, a pre-trend of something else in 2019. You talked about location, 100% agree. Again, it's implicit in the IFR because different locations have different infections, but it's good to be explicit about that and compare it to, for example, the work that Rukmini did, which I think is important. On mobility, exactly right. Now, Sabareesh and I don't 100% agree on this. This is what makes this collaboration great, is that we argue a lot and hopefully get to better answers as a result. I'll give you an argument for thinking about that it is lockdown, that lockdown did reduce mortality, and then an argument for thinking that it doesn't. The argument for thinking that it does is if you go back to our presentation and you look at our monthly chart, you'll notice that the first 2 months after the red line that shows the pandemic, there was a drop. Now, what happened in the first 2 months after we declared that? Lockdown, the national lockdown happened. So one argument you might make is, hey, the lockdown reduced deaths before the epidemic really took off. And okay, so lockdown reduced deaths. Now, that's not a sign the lockdown was good, because it could be the lockdown reduced deaths because it stopped traffic and there are no traffic deaths. But it suggests that lockdown was associated with decline in death. But the flip side is if you go to our later regression, the IFR regression, and you look at the coefficient on mobility, is very small. Now, obviously, you have to scale it for what mobility is, but none of them are statistically significant, suggesting that mobility didn't change much. Plus, adding mobility to that regression does not change the coefficient on IFR on infections, suggesting that maybe mobility wasn't that important. But you're right, it's worthy of investigation, and we'll try to do that going forward. But thank you, those are great comments.
Thanks, Anup. Chinmay, is there anything that you'd like to add? If not, I can just move to some of the questions in the chat box.
Yeah, I think you should move on to that. Thanks a lot, Anup and Sabareesh.
Chinmay, thanks again for the discussion. Anup, Anup and Sabareesh, both of you, there are some questions still open in the Q&A box. There's one question from Arvind Subramanian. It's not managed to come into the Q&A box, but Arvind's question is as follows. Arvind says, if IFR is equal to 0.03%, doesn't that imply infection rates greater than 100% given the estimated excess deaths?
Yeah, I think the IFR numbers should be taken with a grain of salt. That's one reason. Another reason is I would expect that the inflation to go a little bit differently than it does. And the third reason is what Chinmay said, which is what does your infection rates look like? So of the things that we talked about, I think the IFR, the only takeaway you should make is, look, there's a correlation between death, all-cause death in CPHS and where infections were greater. That there's the correlation is positive and significant, tells you that it's a little bit more credible that we're picking up COVID. I would not take seriously that IFR number. I think that requires more work to be credible. So that's what I would take away from that. Sorry, I would say one other thing. I do think that it's helpful to think about the infections, though, because in theory, it's possible to, beyond just finding that these data are credible, maybe come up with some sort of number. I don't think that we've done it just yet in this presentation, but I remain somewhat optimistic that we can get a level number that is meaningful, but it requires more work. Sabareesh, you were going to say something?
Yeah, I mean, again, we think the IFRs should be higher. We do not know what the true estimates are, but if they are low, then it suggests that there were more deaths because of reasons other than COVID rather than COVID. And that's how you'd reconcile with this extrapolation that's going above the population.
Thanks, Sabareesh and Anup. One more question from Arvind, and I'll just get both of his questions in since they weren't able to show up in the Q&A box. Arvind wanted a little bit of clarity on what exactly you mean by wave 1 and wave 2 in your results. And if you can, I think this was a question that also came up in what Chinmay was saying. So it'd be great if you could just talk us through that a little bit, please.
Sure. So, and actually you can use that definition for the pandemic too. And it relates, by the way, to timing. So one should, when doing this, look at different start dates for the pandemic. For example, did it start in February, using the fact that Kerala saw cases for the first time January 31st, the students that came back? Or does it actually start a little bit later once it starts catching on and spreading meaningfully, say in March? So you should vary that around and see what happens to the pandemic estimate during that period. Because the bulk of deaths happen a little bit later, that's typically okay. The main thing that happens is whether or not you're going to take that dip that you saw in our monthly estimates that occurred just after the pandemic. Do you move that before? That's going to be the biggest thing. So the timing of that is going to be an issue. Now, when you're thinking about that in the context of using CPHS data, the thing that makes it a little bit hard is, remember, you're reallocating deaths. You're reallocating deaths from the date they're reported versus the date that you think they actually occurred. And so that's going to interact with your timing for the start of the pandemic. And that's going to be particularly important when you think about the timing of the start of the pandemic. Now, it's also true that you ought to do that for wave 1 and wave 2. To some extent, this is arbitrary when you start one and you end the other. So you could imagine you're going to end them as we do in December and let January be wave 2, or you move it forward and you say, look, Amravati doesn't really see its spike until second week of Feb, so let's not start this till Feb. You could do that too. I don't think that's going to make a massive difference between our wave 1, wave 2 estimates, in part because that's a lull that's going on there. Now, obviously, if you have bigger attributions, like you have non-consecutive months, non-consecutive respondents, and you include that, it's going to be a little bit more fuzzy. But my big takeaway is you should look for robustness across this. For the pandemic, it's those first 2 drops that are going to be the critical to see if it has an effect. And then for wave 1 and wave 2, I'm a little bit less worried. Sabareesh, do you want to add anything?
No, I mean, again, it's basically the timing issue that we cannot fundamentally resolve it. We only know that the deaths happen sometime over the 4 months. However, I just want to point out that our estimates are robust to varying the definitions of the pandemic and the individual waves by a few months, this side and that side. Because our estimates are annualized death rates, I can compare them irrespective of what the duration of the pandemic is, because I'm measuring the death rates for a period of 12 months, for a period of 1 year. And so we can vary the definition of the pandemic, and the results hold up with a variation of 0.01. So from 0.18, it goes to 0.17 or 0.19. It's not very sensitive, and it's in the right direction as well.
Great, thanks. And a last follow-up on that, again, that just came as you were answering this. Just to clarify, on the wave 2, you are limited in the same sense that everybody else that's using CPHS data at the moment is limited, that there's only data until the end of April. So all the data from May onwards, which is a part of wave 23, which is ongoing, will only get released at the end of this wave.
No, we use the income panels. So the monthly income CMI panel for Feb 2021 includes those who responded in June 2021. So we have people, our results include those who were surveyed possibly on 30th June 2021, which is 8 days ago.
I see. Okay, this is very clever. I too was a little confused when I was looking at the slides. So you are using the income data, and for the February data that was released, that was on households that were surveyed between March, April, May, and June. And so you are picking up households whose month slot was June using, okay, very clever. Sorry, this is a bit of an esoteric point, which I think only other CPHS users will catch on to. Of course, you've only got a quarter of all households, because the June households will be staggered over the other months. So that's, you know that. So I'm guessing you're taking that and still continuing to use it, and at least trying to get something out of the data by doing that.
No, I mean, all June household respondents are included in the Feb 2020 income households. Like, we don't have their income in March, April, May, which was also asked, but we don't need the income. We only use the roster. So we have the full June sample.
Mahesh, I'd like to bring you in on this. Is that right?
The June sample size is 142,000.
Sorry, you got to repeat that for me, Kaushik.
So Mahesh, here's the really interesting thing that I've just understood has happened. Our February 2020 income data dropped a few days ago. And even though it's Feb 20 income data, that includes households that were surveyed all the way until the end of June.
Yes, so
And so Anup and Sabareesh are using that information from income pyramids to talk about what's happening even in June.
okay, it's an interesting application. It is very smart.
Yeah. And the follow-up question there was, do they observe the entire June sample just through the income data that's been released for Feb 2020? Sabareesh says yes, and I wanted to bring you in on this just to get your sense on if that was right, or if there's a portion of the June sample that will also show up in other months later.
Well, very small. It'll be negligible. Most of the June sample is surveyed in June, so I don't think there's a problem over there. So what he is trying to do is smart, and I don't think the spilling over of the June sample into July, for example, will make any material difference to his inferences.
Okay, great, Sabareesh and Anup. That's a super clever use of the data. So, from CMI, we congratulate you for really pushing the data as much as you can. That's really great. I see that most of the questions in the Q&A box were answered. I think there's just a couple of comments, really, not necessarily questions. Audience members, if any of your questions have gone unanswered, we will make sure to get those answers from Anup and Sabareesh over email and then get back in touch with you. We're already past 10 p.m. India time, so I don't want to keep all of you waiting much longer. Anup and Sabareesh, thank you for such an interesting and thought-provoking set of results. As Chinmay said, whether it's 2.7 million or 3.35 million or even more, these are really large numbers that we're talking about. And it's very exciting for us at CMI to see CPHS be used in a manner like this. We're very excited to see how this research goes. As you know, and as the audience also knows, next week we have Arvind Subramanian, Justin Sandifer, and Abhishek Anand also presenting their estimates. And that's going to be interesting to see and compare and contrast with the estimates that you have provided this week. I'd also like to take a minute to thank Chinmay. Chinmay, thank you so much for agreeing to do this. We know how busy you are with the work that you are currently doing. And it's been really fascinating to get, I think, a longer term perspective in terms of how to think about these numbers in the context of other, very large events that have happened in India, as well as the, I think, very, very detailed feedback and how they can improve these results and really get at even more questions. So thanks for your time. I will wrap this session up unless Anup, Sabareesh, or Chinmay, you have any final things to say. Otherwise, from us at CMI, thank you very much.
Thank you. Thank you for having
Thank
us.
you.
And thank you, Chinmay.
Thank you, everyone.
Thanks. Bye.